either birth and HSV1, it can be transmitted to the eyes. It can be transmitted to someone else through sharing of spoons and other ways like kissing and etc. Stanley, let's move to the next slide. Where we'll have now the primary infection of HSV. So in childhood, it's usually spread through droplets or direct contact. Let's say during birth, when the mother is giving birth to the child, if there is infected birth canals, that's where it's being transmitted from the mother to the child. Although, like, due to the maternal antibodies that are usually present, it's rare to be transmitted to the child in less than 6 months. So mostly children get infected of the age of 6 months, around 5 years. So uh,
Sorry, Tracy. Adele, who's Adele? Please mute. Thank you. Alafu, if anybody has a question vile inaendelea, you can write the question hapo kwa chat ama utaiandika tu down, utauliza tukimaliza. Proceed.
So the most infections with HSV are usually caused by things like a mild fever, malaise, and upper respiratory tract symptoms. There are also blepharitis and follicular conjunctivitis that may develop, but are usually mild. And the line of treatment of HSV is usually antivirals and steroids. So in the next slide, we'll have recurrent infection. So recurrent infection often it oftenly occurs as follows. Like after now primary infection, the virus is usually carried through the sensory ganglion. Is carried to the sensory ganglion, which is in this case it's in the trigeminal ganglion. So in the trigeminal ganglion, the virus stays there maybe until when it's being stimulated by some factors that we'll see down there. Then we have subclinical reactivation. So this occurs whereby the HSV is shed and the patients are contagious. Then now the clinical reactivation of HSV, whereby, okay, as of after the primary infection, we've seen that the HSV virus will be at the trigeminal ganglion. So when we have factors that will reactivate the virus back to the eye, like for example, stressors such as fever, hormonal changes, ultraviolet radiations, or even traumas, that's where you'll find that the virus now reactivates and it presents in the eye as a, like when you've already transmitted the HSV the first time, it now will stay permanently in your body. It's just a matter of time whereby when you get the factors that will stimulate its reactivation is when you'll have now the recurrent pattern of it. Then the next factor is the pattern of disease. This depends on the site of reactivation, which may be remote from the site of primary diseases. And then there is the rate of ocular recurrence, of which after one episode, like the higher the number of previous attacks, the greater the risk of recurrence. And then we have another factor that is severe diseases, which may be frequently recurrent, including in atopic eye diseases, childhood immunodeficiency, or suppressions. So those are the factors that exacerbate the recurrence of this infection. So are we still together? So we'll move to the next slide. I think I'm done with recurrence. That is now. I hope that you all know the layers of the cornea from the epithelium, from the 5 layers of the cornea. So HSV usually affects the epithelial layer, the stromal layer, and the endothelial layer. So in epithelial layer, it's usually associated with the active virus replication. So when you get a patient with epithelial, now herpes simplex, epithelial keratitis, the symptoms that you might see from these patients are like the symptoms that the patient will report: mild, moderate to moderate discomfort. There is redness, and then photophobia, also watering and blurred vision. And then for the signs and symptoms, we'll have there'll be like swollen opaque epithelial cells arranged in punctate pattern. And then there'll be an ulcer, a dendritic. We'll see a picture of the same. It's a central desquamation result, like it has linear branching ulcers. That is dendritic. We call it. It's called dendritic ulcers. And then the virus laden cells at the margin of the ulcer stains. When you stain the ulcer, it will stain. And then the corneal sensation will also be reduced. And then there might be elevated IOPs. And for this case, for epithelial keratitis, you're not supposed to use steroids to treat the patient, because if you use steroid, it will promote the progression of the virus. And then you'll also see some persistent punctate epithelial erosions, and irregular epithelium may be seen after healing. And then there'll be mild subepithelial haze, which will be persistent after epithelium heals. So those are the signs and symptoms of a patient who is having epithelial keratitis. So we'll go to the next slide where we'll see the investigations, the differential diagnosis, and the treatment. So what you do here, you can scrape off the part of the ulcer, and then it can be taken to the laboratories for culture. And also there is staining, which will show the multinucleated giant cell. So for epithelial keratitis, it has a specific mode of staining. Like, we'll see a there is the dendritic ulcer, or the geographical. It has there is another ulcer that has a geographical pattern, that is geographical ulcer. So for the treatment, the preferred mode of treatment for sorry?
Kwesi kidogo, Omlibrity uni nani? Omlibrity.
Hello?
Mute bana. Omlibrity, mute. Whoever he is.
So the preferred mode of treatment for epithelial keratitis, you'll give the patient topicals, the topical and oral antivirals. So, although for the topical antiviral, you can give acyclovir ointment. And for the tabs, you can give the acyclovir tabs. That's for 5 times a day for 10 days. And as well, in this, while you are treating the epithelial keratitis, you can consider giving antibiotics. That's just for prophylaxis, though. Not it cannot treat the ulcer. Just for prophylaxis. So in the next slide, we'll see the pictures of what I've been talking about. So you can see in the picture A, you can see the way the ulcer for epithelial keratitis is staining under fluorescein. That's fluorescein, okay? Yeah, the way it has stained. And then for the dendritic ulcer, you can see in picture B, the dendritic ulcer, the way it has stained with the fluorescein. Yeah. I think with that, we'll be done with epithelial keratitis. So the next we'll be seeing the deciform, what we call a deciform keratitis. So this is as a result of active HSV infection on the endothelium, or it can be it can be an hypersensitivity reaction to the viral antigen in the cornea. So we have the clinical features of deciform keratitis. So from the symptoms, the patient might will complain of blurred vision, and then there'll be discomfort, redness. Also, the patient can complain of the patient will complain of seeing halos around the lights. And then with the signs and symptoms, we have the central zone of the cornea will be edema with overlying the central zone of the cornea will have an overlying epithelial edema. And then you'll be also able to see large KPs underlying the edema. And then there'll be faults in the Descemet's membrane. And then we can have the cornea will be, the sensation of the cornea will be reduced, and the IOPs might be, like, if you check the IOPs of the patient, you'll find that probably it's elevated. So as of the description, you've seen that the deciform keratitis, the virus is affecting the endothelium of the cornea, and you all know the function of the endothelium. It pumps out fluids from the stroma. So when the endothelium is affected, you find that now the cornea starts to be hazy. And that's what happens in the treatment of deciform keratitis. You'll use topical steroids with the antivirals. So you can use maybe topical steroids. For example, we have prednisolone. You can prescribe pred for topical, and tablets, oral antiviral. So in the next slide, we'll see how deciform keratitis is formed. So in slide 4, not in slide 4, I mean in picture A, you can see the stroma, the epithelial and stroma layers have edema, and there are some basement membrane folds in picture A. I don't know whether you people can see. Yeah. And in picture B, you'll be able to see keratitic KPs. And in picture C, you can see the Wesley ring. So actually, the Wesley ring, it happens when there is a hypersensitivity reaction to foreign antigen. That's where the Wesley ring forms below the stroma. And then in study we have scarring from the recurrent disease. So I've told you that like in HSV, you find that it's mostly recurrent because when it gets into your system, it will be there like forever. It only needs to be triggered for it to present in your eyes. So that's I think it's all about the deciform keratitis. So you see hello Stanley, are you getting me?
Yes, we are in the necrotizing, right?
Yes.
Yeah, and that's the screen that I'm sharing, unless you're not able to see it from your end.
Yeah, so we have necrotizing stromal keratitis. This is as a result of active viral replication within the stroma. So like now there is the replication of the virus in the stromal layer. The signs and symptoms of the patient with necrotic stromal keratitis, you'll see stromal necrosis and melting oftenly with profound interstitial opacification. And then in this necrotizing stromal keratitis as well, you'll have anterior uveitis with KPs underlying the area of the active stromal infiltration. There'll also be an epithelial defect that may be present. Also progression of scarring, and there'll be vascularization and lipid deposition and deposition. So we'll have the treatment of necrotizing stromal keratitis. I think we are moving to the next slide. Okay, that's first the picture of necrotizing stromal keratitis. And for necrotizing stromal keratitis, actually, it may be difficult to distinguish it from deciform keratitis. So no, we are yeah, the picture of necrotizing stromal keratitis. So for the treatment of necrotizing stromal keratitis, actually is the same as that of bisiform keratitis. You will use topical steroids, and also you supplement it with oral antivirals. Then we also have neurotrophic keratopathy, and it is caused by failure of reepithelialization resulting from corneal anesthesia. It's often exacerbated by other factors such as drug toxicity. And the signs and symptoms of this is you see it will there will be an unhealing epithelial defect, which is caused by prolonged topical treatment. And the stroma also, like the stroma beneath the defects, it can be gray in color and opaque, and there can be also secondary bacterial or fungal infection that may occur during this stage. The treatment for neurotrophic keratopathy, you use steroids, that is to control the inflammatory component. You use steroids to control the inflammatory components, and that's the picture of it's a neurotrophic. It's stained with rose bengal. Then finally we have the complications of these. We have the complications of HSV. So we have the secondary infection. So we have the secondary infection. Hepatic I is actually the major predisposing factor for microbial keratitis. Then we'll also have glaucoma. Glaucoma also can be a complication for this, which is so as you had seen, like in endothelial keratitis, there might be a risk of high IOPs, and as far as the IOPs are high, there is risk for glaucoma. And it is okay. The rise of IOPs is due to corneal thinning and distortion. So it may give a rise in the intraocular pressure. Then we have cataracts. Cataract also is secondary to inflammation or prolonged steroid use. As of endothelial keratitis and stromal keratitis, you use steroids to treat the same. But then since this HSV is recurrent, so the more someone uses steroids for a long time, it can lead to formation of cataracts. And then there is also iris atrophy, which is secondary to keratouveitis. So up to there, I think I've covered all the slides that I had prepared on HSV. Unless anyone has a question or an additional point. Yeah.
Thank you very much, Tracy, Chef Coril. We appreciate what you have done. So, if anybody has a question, now is the time to ask. We have, I think, around 5 minutes hivi tufunge hii shughuli. So, questions, comments, Mr. Stanley, I think your hand is up.
Yes,
Yeah, you have the floor.
when we look at the pictures, we see that the cornea in these cases were inakaa very scary, and I think it might be that kuna perforation. So what are the considerations in prescribing steroids? Because we know that steroids, if they get into infections, it's another issue. So what are the considerations? When do you use steroids? When do you not use steroids? Yeah.
Okay.
Tracy, I think that question is for you. Before you answer that,
Yes.
we have another question hapo kwa chat. What causes elevated IOP in deciform deciform keratitis? Yeah, so you can say it.
Yes,
So
yes, I
I think you
can.
can respond to the two questions as any other person who has a question prepares to ask.
Okay. So when do we use steroids and when not to use steroids in treatment of HSV? So when to use steroids, I'll start with when to use steroids, and let me start with when not to use steroids, because I started with my presentation. I started with epithelial keratitis, and if you can all remember well, I mentioned that in epithelial keratitis there is formation of ulcer. There is formation of an ulcer. There was dendritic ulcer, geographical ulcer. So when the patient comes to the clinic and when you stain the eye and it stains, so you're not supposed to use steroids to treat that patient. But when you stain the eye and it doesn't stain, for the case of deciform keratitis and stromal keratitis, if you stain that eye, it won't stain, but you'll just see the haziness of the cornea, but it won't stain. So it means there is no ulcer. So then is where you can be able to use steroids to treat the ulcer, because to treat not the ulcer, to treat that eye. So when it stains is when you don't use steroids. When it doesn't stain is when you can use steroids.